Hi, Dr. Saumya.
Hello.
Hi
Didi.
everyone. How are you?
Hi.
People are joining. How are you?
Hi.
Hi.
Hi, Alexander.
Good.
Hi.
Hi, Deepak.
Hello.
Hi, everybody.
Hi.
Anita, you're the boss, so you can, whenever you want, you can start with your talk, and then the cases.
Do you want to give a few more minutes so that more people are on?
Yeah. Maybe a couple more minutes, sure.
Yeah. We'll just get just say hi and see how everybody is.
Yeah.
So just in brief, maybe I'll just go through. I will just give a short, because during the last MDT, we had discussed there were some challenges about doing the whole globes into one slide. So and some of the glossing details. So I presented this talk at the ISOO in Africa for the pathology meeting, and I'm just giving just a few slides summary of the key points for grossing a globe. And I have a short video to show how we just go from glossing to cutting the slides on so that the whole globe fits onto one normal slide. So just to give you an idea of how we do it. And then after that, we will go through the cases. We have 2 cases, if I'm not mistaken, that for discussion. Maybe we can spend about 20 minutes or slightly longer, and we can have Dr. Alexandre Moulin from Switzerland and Dr. Saumya to give some comments on the cases. It's nice to see everybody. Welcome. We're just going to take a little bit of time to join in because we hope that there'll be more people on.
We also have a young baby with us. Yeah.
Yes. Welcome, everybody. So I think if you can just keep it muted so that it doesn't distract people when we're actually going through the presentation. And I thank you everybody for taking the time off. I think for you, some of the timing is either very early or very late. It's 9 p.m. for me in Singapore. Yeah. I think we have a fair number. And it's just let's just give it. It's just 9:01. So can we maybe give it a few more minutes? Maybe we'll start at 9:05. Just I see a lot of people joining in.
Let me just remind you, 2014 is 10 years. I'll show you again. Okay, 2023.
Dr. Anita, how many presentations do we have?
We have 2, right? Dr.
That is from. So are we only having presentations from Kenya, or are there other presentations?
I think
Only from Kenya, only yours.
Okay, so we have 3 cases. Then we have 3 cases, but they are all pretty short.
So we're Dr. Waweru, you presenting 3 cases, or is Dr. Kimani
Kahaki will present the clinical case and followed by the pathology.
Yeah.
So you have 3 cases?
3 cases.
Okay.
But, so we will do it simultaneously. So I just present the clinical aspect, then Dr. Waweru presents the pathology aspect, then we move on to the next case.
Do you want to have Dr. Saumya and Dr. Alexandre comment a little bit first on each case before we move on?
Yes, we can do that. So we finish one case and move to the next.
Yes, then I'll just keep time to make sure we have adequate for each case, and so that we make sure that we have enough time for each case.
Okay, I'm just hoping that my Wi-Fi will be good. I'm out in the village and it might break a bit. I'm hoping it will behave.
It is doing very well now.
Start. I mean, we're good to go.
Okay.
Yeah. Okay.
So maybe I could already.
No, but I think Kahaki Anita will start with the short presentation on.
Yes.
Just a few slides only. So I'll let me share screen, and then we can start with this first. And then, so thank you everybody for coming. I just wanted to share a few slides. This is what I presented at ISO in Africa last year, and I'd like to share this with you again. So I just want to go through some of the key landmarks for orientation for those that don't frequently handle globes. Typically, we'll look at the globe and turn it to the back and try to identify these key landmarks, such as the long posterior ciliary vessels, as you can see in the box here. This helps me identify the horizontal plane of the globe. Sometimes this globe is quite normal looking, so it's easy. Sometimes the globes that come with tumor can be very disorganized, so you can try to look for this landmark. After this, I would usually try to look for the superior muscle complex, as you can see with the blue arrow there. That's the superior rectus. And usually it comes with the superior oblique tendon as well. So that will be the superior muscle complex. And from there, you can turn the globe around and know where the top of the globe is, the superior aspect. Then I'll try to look for the inferior oblique. And this is usually in the inferior temporal quadrant. So if you see the stump of the inferior oblique on the right side, that means it's the right eye. And if it's on the left side, it's on the left eye. So that will help you orientate which eye it is that the specimen comes from. And I just want to highlight, sometimes when you see the globe, you want to take some measurements. So most of us pathologists, we are used to adult globes, but children globes are slightly smaller. And I've given you here the average range for the normal eye of a younger child, like 1 to 3 years old. And if you see that the globe is larger or beyond this range, then you want to be careful that this eye maybe has ophthalmos, because the tumor is growing very big and the eye is larger than normal. And you may look out for features of glaucoma, or be aware that it's going to be a very big tumor that is causing the globe to be larger. Again, also the optic nerve parameters, you measure the diameter and length, but you want to take note that the child's optic nerve is usually thinner than that of an adult. So if you find that it's enlarged beyond this range, then you be careful to make sure you exclude that there's the optic nerve extension. So this is something at the time of grossing you can be aware of, and so that when you do the trimming, you make sure you look out for these. As well as looking at any of the external surfaces, look carefully, especially after you cut the globe. You can look externally before you cut the globe, and after you cut the globe, look at the sclera to see if there's extrascleral extension from the choroid as well. So if you have a smaller globe, it's useful to do a transillumination like this. You can really see where the tumor is, and that can help you when you do the pupil optic section, because you want the pupil optic section to have the pupil and the optic nerve as well as the tumor. Obviously, if you have a very large tumor, you will just get this loss of transillumination, will be opaque. So in my center, we don't do tumor sampling for genetics. So we just keep the whole eyeball, and we like to fix it at least 2 days. Minimum is 1 hour, but 2 hours will give you a much better fixation, so it's easier for you to cut the eye open. As you know, the tumor is quite friable, so it gives you a longer time to make sure that the tumor becomes a little bit more firm. Some people even fix it longer, but 48 hours, 2 days is fairly good. Before you cut the eye, always make sure you take the shave optic nerve margin if the surgeon has not already done that for you. In my center, they don't. It comes together with the globe, so I will cut that off first to make sure I don't contaminate the globe with because once you cut open the eye, you know the tumor just spills everywhere, and it might contaminate the nerve. So do that first and put it aside for embedding. Then you do the PO section, as you can see in the purple. And then after that, you will do the bread loafing of the calottes on either side, and you pass that. So this is just an example. Depending if you have a small tumor, however, it's a very big tumor, I like to do a horizontal section, because that will give me an idea of the macula. So your first cut will give you this calotte. Your other cut will give you the PO section as well as the superior calotte. And after that, remember to bread loaf it. And this is how we normally put it in the cassettes, the not regular size cassettes with the PO section as well as the calottes. And that will allow you to examine all the tissue, the whole globe, for any choroidal invasion. This is what I normally do. If my PO section is quite thick and I can't fit it into the normal cassette, as you can see here, the sectioning is quite thick. I sometimes put it in this bigger cassette. This cassette is usually called a whole mount cassette. So I process it in the whole mount cassette. The optic nerve margin I put aside. And I like to do the true surgical margin embedded face down so that it doesn't flip around and I lose, which is the cut section. We then take the tissue and put it in this adjustable mold so that it fits the same size, and we pour paraffin inside. And then we can come up with this block that fits the same cassette, although it's a lot thicker, but it's still the same size as the cassette, regular cassette. And this is just a short video to show we do the trans-illumination. We can mark out the area where the tumor is. And this is how we cut with the blade to get 1 kilot. And how you hold it carefully, cut with another blade to get another. And then after that, this is just to show you how we cut it onto that, how I process it, as I mentioned just now. So you can have it onto a single side, and then you can fish it out into this regular slice. You don't need a large side, and it just about fits for the whole eye. So this is a sample of what we get, the whole section, and with the tumor involved, right? And yeah, just mention that make sure you have adequate fixation. Make sure you do the proper external globe measurements. Trans-illumination is useful for finding a tumor. Although in very advanced cases, I understand in Africa, sometimes the whole eye was already opaque. And just remember the key points with the trimming and the serial sectioning for the calots. Yeah, that was just a brief overview, and I'll stop sharing, and we can we'll take questions later on this if you want more questions to ask me any questions, but let's go on to the case presentation first. So please continue with the case presentations.
Thank you very much. Let me try and screen share. I hope it will work. So it is telling me to ask owner to share pathology MDT for retinoblastoma. So I think I don't have the rights to share.
Oh, you don't have the rights to share?
Okay, let me try
the...
Dr. Kahaki.
Okay.
It's multiple participants can share, so I don't think that's a problem.
Yeah, okay.
So let Dr. Waweru try to share.
Are you able to see it?
Israel. He's the one.
Are you able to see?
Yes, we can see it. Thank you.
He's the one taking care of that child. I even send on that there.
Okay.
Okay, so what's going on? So maybe let me just present the first case. So this was a male patient, MC, born 1st May 2016. So when he came to us, he was 7 years old, and the history that we got was that he had loss of vision in the right eye for 1 year, and a white reflex in that eye for 5 months. And what we gathered from the parents is that he had suffered some trauma in that eye and had been seen in a health facility where some medication was given, and the eye didn't have many issues until like a few months later, when they noticed that he couldn't see with that eye. And then later on, after about 7 months, they noticed that he wasn't, that there was a white reflex in that eye. And they took him to a hospital where he was seen by the vitreoretinal surgeon, and the vitreoretinal surgeon thought it was a vitreous hemorrhage. He was scheduled for vitrectomy, but during the vitrectomy, they found that there was a mass in the eye. And so what they did was take a vitreous sample, gave it to the patient, and sent the patient to our hospital. So when we saw him, that was in probably about 3 days later, in May 2023, the right eye was inflamed, the cornea was hazy, the anterior chamber was shallow, the pupil was amaurotic, and all we could see there was, we could vaguely see a mass in the vitreous, but also with associated hemorrhage. So we scheduled him for enucleation immediately, and we enucleated the right eye. However, when we examined his left eye, so that he had a small peripheral mass, which was possible to do transpupillary thermotherapy, and we did that. Then we scheduled him for systemic high-dose vincristine, etoposide, and carboplatin. He received 6 courses, and he has already undergone 45 grays of external beam radiation in that socket. And he has also received another 6 courses of high-dose vincristine, etoposide, and carboplatin, and has been stable all this time. And after the first transpupillary thermotherapy, the mass in the left eye flattened, and he has not had any recurrences. So what was interesting about this patient was having a bilateral retinoblastoma very late in life, and also now what had gone on with the eye. So we are treating him for orbital disease based on the iatrogenic. We are treating him as iatrogenic orbital disease because of the vitrectomy that he had undergone. So Dr. Waweru.
Okay. So move to the next slide.
You muted yourself.
So,
okay.
Yeah, okay. Yeah, so in pathology, we received a right eye for MK. I won't repeat that. Initially, vitrectomy was reported as having malignant round blue cell consistent with retinoblastoma. I don't have those slides to show you. And when the enucleation was done, we got the eye and was processed in the department. We used a pro forma modeled along the CAP protocols, where we fill in some of the details. And I have just extracted some of the information. So those were the measurements, the AP measurement, 2.2 centimeters, horizontal 2.4, and vertical 1.8 centimeters. The optic nerve thickness at the distal end was 2 millimeters, and at the proximal end, 2 millimeters. And the tumor at the base was 15 millimeters, and the height was 13 millimeters. On microscopy, the structures that were involved was the vitreous and the choroid, and the nerve, the tumor was in the prelaminar around the optic nerve, in the prelaminar region. The resection margins were negative, and other surgical margins negative. And so this was reported as a T2A as intraocular with local invasion. And we usually have a summary of what we have ticked. And this is summarized as a right eye enucleation of undifferentiated retinoblastoma based on the rosettes that we see with choroidal invasion less than 3 millimeters and pre-laminar optic invasion and optic nerve resection margin negative. So I'll show you some of our images, and I apologize, they are a bit thick, but you'll see as they are. Okay, so it wasn't a very large tumor, and so most of the areas with the tumor were all drawn towards the middle of the vitreous. And on the left, we can see what is going on, a detachment.
I think that it was a trauma.
Okay,
that's a child trauma.
Okay, so we can see bits of the tumor and a bit of thickening within the retina. And in the areas, some areas with the tumor, we could see clear-cut necrosis. And the tumor here, the cells didn't focus too well because of the thickness. Okay, some of the ocular structures that were clearly not involved by tumor, and you can see that only it was a localized tumor. There wasn't much of the choroidal involvement. Okay, so that was what we saw to generate the report that we generated. And that gives us the end of this presentation. And like we said, we should allow for questions.
Dr. Saumya, do you have any comments?
Yeah. So were any other anterior structures or the port site? Did you see the port site within the sections? Were you able to make out the port site where the surgery was done previously?
From the sections that I had, I think that was not taken into account because I was not able to localize that site. Probably that's where we shall learn from your team, because it's not very often that we get eyes that they've already done a procedure. So what do you do when you have an eye where you've had, say, vitrectomy done?
So ideally, the first optic nerve pupillary callet the cut has to go through the like one of the cuts can go through the port site, whether it is horizontal or oblique or vertical section. Try to get a cut through the port so that we can know if there is any direct extension into the orbit. That is one point. And the other thing is that are you sure that have you taken all the callets? Because the tumor looks very undifferentiated and there's a lot of necrosis. So undifferentiated tumors usually have more of propensity into the choroid. So was only 2 mm involved at one location or at multiple locations? That was one more question I had.
Okay, I took limited images. The PO, let me see if I can go back. Yes, this image was from the PO section that we had. We had cut like 3 of them for this particular one. There were 3 of them, and this tumor was part of the structures that we had in the middle. What I'm showing here was from one of the colors.
Okay.
So I didn't quite get the question that you are talking about.
So I just wanted to know the status of the port side, because if there is any direct extension that I can demonstrate here.
No, unfortunately, I think That is, I think that is a new thing to us. I don't know how many Dr. Kahaki can confirm how many of the resections they've given us that they've done a procedure before. Most of the time, it's the virgin eye, they haven't done a procedure. So that could be an oversight on our side. A good point, actually, I should say.
Dr. Moulin, would you like to comment on anything?
Well, what we usually do for these globes, but I don't know if you guys have immunohistochemistry, is that we always complement the cases because you know that there are now these two categories of retinoblastoma, and now we look also for all the cases we look at RB to be sure that whether RB is lost or not. If RB is present, in some cases, then we will look at MIC-N, and we also look at phospho-RB to see whether it's present, and whether RB is inactivated by phosphorylation. So that we can regularly do, and what we also assess, according to the publication by the Curie group about this subtype 2 category, it's like we also assess TFF1 to see whether, because we know that the TFF1 is supposed to be subtype 2 retinoblastoma that has a higher propensity to metastasis, and it's a high risk. I don't think that is yet a prognostic factor, but maybe in the future it might be useful. So I don't know if all you guys have access to immunohistochemistry or not. I mean, this is something that we do regularly on all cases, and we are extremely obsessive about sectioning of the globe. And the way we process the globe, I mean, the globe, when we include them, the deshydration process is longer than 2 days. It's like 3 or 4 days. And afterwards, we cut the globe usually through the center, and then we cut serially up to the moment that we see everything that we want to see. And we sometimes rotate the block in the other direction to cut in the other direction to see if there is a deep involvement of the choroid. But that's the way how we process here. But we usually do between 40, sometimes 50 sections per enucleation. That's quite a lot. So I don't know if you guys are doing so many sections as we are doing.
Yes, we do
That's
it.
You're able to do those many sections?
Yes.
Oh, okay. I think, Kahaki, that is something to think about. We routinely do a minimum of 4, but we can cut more when there's tumor, because most of the time we are just confirming that tumor is there and the structures involved. I think when we start getting the disease earlier, we might be forced to cut more and more of these sections. I don't know how much we could be missing by limiting the processing. Most of this is done in our national hospital with limited resources, but I believe as we get the disease earlier, we will have no choice but to process more. Now, the question is, what would be the recommendation? Are the rest doing those number of slides in all their centers, or how would what kind of a guideline would have? Because if we were to suggest we do 40, even if we are not getting many cases in total, we might not be supported by the institution for that. Yes, yes.
Dr. Saumya,
we may do for a single case, but as a routine, that I don't know whether we can sustain.
So in India, what we do is that the central callet, until we see a proper lamina cribrosa, we take serial sections until then. And probably that would be around 20 to 25 until we see a normal lamina cribrosa. And rest of the peripheral callets, I think we restrict our sections to 10. And we just see this for, for routine screening. And in case we have any doubt, then we go and ask for deeper sections for that particular callet. And if we have to look for choroid invasion and all, and if we are very suspicious, because it's very tricky sometimes that you will not be sure whether there is the Brooks membrane intact or it is lost, then we run a pass stain just to confirm whether the Brooks is present or not in that particular callet.
Okay. Okay, that's helpful.
Are there any kind of international guidelines, or it's a matter of local protocol?
No, I don't think so. There is a very strict consensus anywhere. This is what we follow here in India.
I think there are some guidelines as what you have to do. Like I showed just now, you make the calotte and the rest you bread loaf them, and you can put them, so you can see that I have at least 4 cassettes when I showed the slides with the PO and each calotte. If you don't bunch them up, you can actually split it to 2 separate. So I had like 2 calottes, two cassettes for the bread loaves of the calottes, 1 for the PO section, another 2 for the the remaining calotte, because those would be bread loaf. And in that way, so like I'm just, you look at the external globe. Like in this case, they had surgery. So you would sort of like look around the site where you expect the surgery to see if you can see any scarring or any tumor extension. Because for you to treat, because you mentioned you're treating it for orbital protocol because of the surgery. So you really want to see if there's any extra, lesion on the front of the eye. And from there, you may want to be more careful when you cut. And then once because we pass everything, be able to look at the sclera. Like I mentioned, after you cut, you look at the sclera, the white, is it thinned out? And that sometimes will give you a clue that you have extension beyond, or it's very thickened, or what the changes there. Sometimes we even use the dissecting microscope to look under high power to look for areas that we're more suspicious of. So if you cannot do so many sections, you try to look at the gross for more suspicious areas and maybe focus on those, so that you can sort of minimize having to cut so many. But if you have the capacity to cut more sections, then obviously based on what you see, you would go deeper. So that's how you can sort of like a compromise on not doing so many sections by just looking more carefully on the gross specimen, maybe even with the dissecting microscopes to look for areas of irregularities where the tumor could be there. And then you can focus on that area to minimize how much you process. But so one way to minimize even more cassettes, although it will be bunched up, you can put all the serial sections, cut it very thinly, and put them in one cassette and then block them on one slide. But I sometimes don't like that, because when you cut, you'll know that they're all irregular. You have to cut many deeper. So another trick is your globe. When you see the optic nerve, you can mark it out for the people who are trimming it, and you don't have to process each size, but when you cut it, you go until you see the area exposed. Then you make that into a H&E section, but you can cut deeper first. But what I didn't show, but sometimes what I do is I order the deepers. I ask them to keep the slides as spares, just in case I missed something, and then we can go back and restain them. That's another thing that we do. So you don't have to make all the H&Es, but you can keep the slides as unstained. Then you do the one that you think that has, because you can look at it grossly. You really have to train the staff to look at the paraffin block to see where the lamina cribrosa is, and then you can just go deeper. And after a while, they will get the hang of it, because usually it takes about 20, depending on the size of the globe, you roughly will know that it's about 20 deeper sections. So they will know, and then you just keep some spares in between. So that's how we sometimes do it to, like in all labs, we may not have the luxury to do so many slides. This is how you can minimize it a bit.
Okay, there was the question of immunos. In our setup, we don't routinely do them unless maybe we have an exenteration and we are not very sure the tumor we are dealing with. Most of the time, we don't do the immunos. I don't know what the experience is with the rest of the team.
Dr. Saumya, do you do the prognostic immunos or MIC?
No, Dr. Anita, we don't.
Yeah, we don't do that here as well. Routinely, we make maybe some centers do it, especially in the very aggressive looking tumors, but we don't do that routinely. We don't have enough load to have the antibodies as well. So yeah, we don't do that.
So I'm not a pathologist, I'm on the clinical part, but our pathology institution does NMIC immunostaining and also FISH analysis for both NMIC and RB. So for FISH for RB is not very sensitive, but it is for NMIC amplification. And of course, we do blood sampling for genetic analysis as well. And then we compare to see if it's a germline case, if it's a sporadic case, somatic case, or as you've mentioned, those young infants, about 6-month-old presentation with unilateral sporadic disease or NMIC amplification. There was a paper by Brenda Galli's group in 2013 in Lancet Oncology where they first presented this subset of retinoblastoma in about 1.5% of the cases.
Usually when you see these cases, they have a tendency to have a deep choroidal invasion, and we've seen cases that also were invading the ciliary body, the SMIC-N amplified cases. And when you look at the cell, they are more rounded, and they are quite, I mean, we've seen quite a few of them, and usually they have really a tendency to display an exophytic type of growth. And that's, and one thing that was mentioned to stress out also about microscopy that can be important, that's what we do always in the cases, is to ink with 2 color. Because if you want to know where there is an let's say, suppose there is an exorization and that you might have missed macroscopically, then you precisely know where exactly you are if you have with your 2 color ink. That's also very important to know, whether it's a superior, inferior, so you can precisely tell exactly where you are when you look at the slides.
Another thing concerning the MIC-N amplified cases, I don't know if you can hear me well.
Yes, you're audible.
Yeah, they have very prominent nucleoli, the cells. They have very round nuclei, but very prominent nucleoli, which are very bizarre for classical retinoblastomas. I'm a pathologist from France, by the way, from Institut Curie. And I had another question to Alexandre. Do you do the immunos systematically, the TFF1 and the RB? Do you do it on all of the cases? Because we do it here for research purposes, but not on routine cases.
Yeah, for us, there's also kind of a mix between research and routine. So we do on all the cases, yes.
Okay. And do you base your decisions or clinical decisions on some of the results, or for the TFF1, for example?
That we have to discuss with Maya Beck, but I mean, you know, if we have post-laminar invasion plus choroidal invasion plus TFF1, then it might weight more in the balance is additional chemo.
Okay, thank you.
Maybe I just wanted to mention one of the things we learned from this case is that for a patient who has undergone a surgical procedure, because once in a while we'll get a patient who has undergone cataract surgery or vitrectomy, and yet it was retinoblastoma, then maybe as clinicians, we will mark the areas, the ports of entry into the eye, so that maybe as the pathologist is looking at the eye, they would know where specifically to look for extraocular disease. But as it is in this case, despite there being no high risk factors, we are still treating this child as we would a high risk pathology. Thank you.
Okay, I think that will be helpful. If you alert us that you have already done surgery on the patient, that will help us when we are processing. I think because it's not a routine thing, you will have to be alerting us. Then we see if we can be able to process as advised. Do I move to the next one?
Yes, I think you should move to the next one. Thank you for the interesting discussion from everyone.
So our next patient, this case, the reason why we are presenting it is because this is a child who we have been treating since 2014, attempting to save her only eye. She was born in April 2014, and she was referred to us from another hospital where they had enucleated her right eye, which showed no high-risk pathology features, but there was tumor in her left eye, and that's why she was referred to us. So the picture you see there on the top left, that was the first time when we did the EUA on her. As you can see, she has these two big tumors that are juxtapapillary to the optic nerve, and they are actually all over the macular area. But she responded very well to chemo reduction. So the second picture you see there on the top is a picture after 6 courses of chemotherapy. And at this point, we started focal therapy, and we thought that we were in the clear. And as soon as we thought that we were in the clear, then we got a recurrence and we had to resume chemotherapy. And this kept happening almost like you could almost predict that when things are looking good, you have given chemo, you have done focal therapy, probably within a month, you'll have a recurrence. And eventually, after many courses of chemotherapy and repeated recurrences, we tried intra-arterial chemotherapy, and she got intra-arterial chemotherapy twice. That didn't so with good response, but then later developed recurrence. And finally, they were able to raise money to go to LV Prasad Eye Institute. And we had referred her there for brachytherapy, hoping that finally we will control this disease, because in spite of the way it looks here, she still had reasonable vision, was attending normal school. And finally, like a month after, or maybe like 3 weeks after returning from India, after the brachytherapy, she came back with this mass in the anterior chamber. And we even tried to deny that it could not be a mass. In fact, she was, for a while, she was even treated for like severe uveitis. But finally, we did anterior chamber tap, got some aqueous and sent it to the pathology lab, and it showed that she had tumor cells in the anterior chamber. And so we had to enucleate this eye, and we sent it for pathology. So maybe if you move on to the next slide, or that is all that we did for this child. But actually, after we got the pathology report, we still had to give her more chemotherapy because there were high-risk pathology features. So Dr. Waweru, you can move on.
Okay, so we got the eye for, no, that is what you were talking about.
Yes.
Okay, so we got the eye and processed, and there was quite a bit of tumor involving about 70% of the retina. And on microscopy, the ocular structures involved were quite many. The sclera was involved, I'll show you that. The vitreous was full of tumor. The ciliary body was involved. The angle was involved. And there was massive choroidal invasion at 6 millimeter. And it was within the lamina. It had extended within the lamina, but the resection margin was negative, and we didn't have the tumor outside. The cytology report just showed that there were tumor cells, but I couldn't trace the slide. We're in a teaching institution, and so it could be with somebody who's teaching the students with it. And so this was reported as a PT3A with massive choroidal invasion and those other structures. And we summarize as the left eye enucleation, poorly differentiated retinoblastoma with massive choroidal invasion, prelaminar invasion, and no, laminar invasion, and optic nerve resection margins negative. Okay, so I start here with, this is how most of it looked like, full of tumor. And you can see that there was quite a bit of tearing as they were processing, but there's tumor right through, and I show it at a higher power here to show that these are actually tumor cells. Let me give a pointer. That these are actually tumor cells, they are not inflammatory cells. They're actually tumor cells, and it was around there. Quite thick also. And you can also see that we have tumor infiltrating, and also this is the optic nerve end where we have the tumor in the lamina. Unfortunately, the sections were very thick. I couldn't be able to get better ones with what we had there. And so we are still able to see that there's obvious tumor. Anteriorly, you can see, I think this was part of what was being seen, and there's a tumor going all the way and also close to the lens. Okay, so that those are the images that I took for the second case. We pause for the questions here.
Yeah. Were the meningeal spaces involved by any chance? Can you go back to the optic nerve image, the previous slide? Okay. No, I guess.
No.
Okay. And was the sclera a full thick? I mean, was there any full thickness involvement of the sclera, or it was partial?
I think it went beyond 2/3, but not quite right through. But it went close to about 2/3 of the sclera. I couldn't see the original slides. We had to cut again. And okay, there's a bit of tearing here, but it looked like 2/3 of the sclera was involved.
Yeah, because why I'm asking is if that area was involved, then it'll the grade increases to T4.
Yeah, that's what I was thinking. It was reported by a colleague, and I was thinking that with the involvement that I saw in the sclera, but I've just learned from what you have just told us, if you cut deeper, then you might see more than what you have seen with the initial cut. So I have no way of confirming, and that's why I hesitated, but it was reported as T3, but there's a possibility that it's actually a T4 with the scleral involvement.
And one other comment, did you look for the emissary vessels in the sclera?
No.
That would be another point in addition when there is a scleral involvement that we have to look into the emissary vessels.
Okay.
There could be tumor emboli in them.
Okay. I think that I also didn't check that, and it was not reported.
Any other comments? Dr. Moulin, would you like to comment?
As we wait for Dr. Moulin to comment, one of the reasons why I brought this patient is because now we have seen what the pathology report indicated. This child had already received brachytherapy, so that was radiation. So the radio-oncologists are very reluctant to give more radiotherapy. And so we were a bit stuck on how much more do we need to do in terms of treatment of this girl.
Again, about I don't see any ink on the scleral side, but to me it looks, I think it is very likely that the tumor cells go up to the scleral margin and that the scleral margin could be positive. And I agree with what has been said before. it's true that we always look sometimes at the vessels, and sometimes you have retinoblastoma that behave as melanoma, and they go through the scleral channel and invade sometimes the vessels, as melanoma do. So that's also something very important to take into account. But to me, I would regard this case with a positive scleral margin, I think, unfortunately.
Okay, point taken.
Are there any more questions you'd like to ask or comments? If not, we can move on to the next case.
Children, and I pronounce it.
So that case actually is not a retinoblastoma case, but it was quite an interesting case because this is a child. This is a child we saw in June last year, and he came with history of a white reflex in the right eye since birth. So when we saw him, he was 11 months old. No, he was 13 months old. And when we examined, it looked like retinoblastoma. And we went on to a nuclear eye.
Sorry, somebody can mute the Dr. Bavadia, can you mute your microphone?
Okay, so when we enucleated this eye, we found the optic nerve to be thickened. It didn't appear typically like what you would see in an optic nerve thickened by tumor. It was a bit fatty, but 6 millimeters thick at the base. And based on this, we thought we are dealing with extraocular retinoblastoma, and actually started the child on chemotherapy immediately after the enucleation, but we stopped the chemotherapy after histology, which Dr. Wairimu will discuss. Dr. Waweru?
Yeah, okay. So in this, the report was just read Coats disease, and after Dr. Kahaki mentioned that they were concerned about optic nerve thickness, there's no explanation from my end, and maybe we can hear from you what that would be. So that's how the eye looked like, the areas that I photographed. You can see the retinal detachment, the vitreous full of bubbly foamy macrophages, some with pigment. That's how the PO section looks like. And this is the area of the optic nerve. And I looked at it, and I don't know. I don't have any idea what is going on here, and probably will hear from those who know better, because there's no tumor. I looked at it under high power. I don't have high power, and I didn't see tumor. Probably will hear from those who understand what's going on, why there was that thickness that made them think of retinoblastoma. But all the sections basically looked like that. And where we had the retinal tissue, that's how it looked. We didn't have any other area with the suspicion of tumor. And so I took the higher view of the optic end so that we can hear what the explanation for that would be.
Dr. Kahaki, was there any raised intraocular pressure in this child?
When we first saw the child, the pressure was about 21, so not significantly raised, although we thought it was a bit high for a child, but with no other features of ophthalmos.
And Dr. Waweru, how were the angles? in the slide, like where they're open? Did you have any features of glaucoma? That's what my question is.
I have to admit that element didn't even enter my thought. What would we be looking for?
No, sometimes there would be optic nerve cupping and all in glaucoma. I mean, in cases such as sports, sometimes the angles get obliterated, not closed, but they get obliterated because of the subretinal fluid which is being collected there. So it often we see that in our slides.
Okay, I'll look out for that. I don't have much experience in that.
Dr. Moulin, would you like to comment?
Well, for me, it's difficult to, I mean, from the retinal detachment and the scalloped edge with the macrophages, it can look like really like a Coats disease, but the aspect of the optic nerve, the magnification is not big enough for me to see what's going on. I mean, there seem to be with some foamy cells, so would like to go higher mag to see what is really going on. We've seen cases where radiologists have had impression of, but these are in treated case where they had the impression there was tumor in the optic nerve, and actually this was a reactive hyperplasia of the RPE covering the optic nerve. And sometimes the radiologists cannot make the distinction between these two entities, active retinoblastoma or reactive RPE changes. So it's difficult, but in this case, I would need to go higher mag in the optic nerve to assess what's going on in there.
Okay.
Yeah, in this case, it's a bit hard to assess the lamina cribosa. It looks like there's a hint of it, and then, but it's not very clear that where the lamina cribosa is. So sometimes you may be able to do some simple stains to highlight the lamina cribosa to see if it's bowed backwards. Yeah, it's a little bit hard for us to see. It would be nice to see the full length of the optic nerve, so that we can comment further, rather than just the optic nerve head, like towards, because if you look at the slide, the posterior part, just focusing on that posterior part with the adjacent fatty tissue would probably give us maybe a better idea of what might be going on in the optic nerve. In the picture of the retina that you showed, there's not much exudates within the retina itself. I think I didn't get to see, but it's a bit disorganized. So did you see a lot of exudates in the rest of the retina?
No.
It's a bit it's already a bit gliotic here and not very well formed, so it's hard to assess. But definitely there's a lot of subretinal fluid going on.
What should we watch out for if we go deeper on this section?
Just to see what is, because we can't really assess, like, but we do see that the optic nerve is a little bit thicker on the posterior aspect, and there's some fat around it. So there might be something that, like maybe the optic nerve cells are maybe like hyperplastic. We can't really tell because the stain is a little bit darker than usual. It looks, so if you ask, it looks a little bit more cellular than usual than your typical optic nerve. But otherwise, I don't know whether it's because of tooth. It's a thicker section. So
thickness. I think it's a thickness.
Thickness, right? So just have a look, because it looks a little bit more cellular on this low power. So yeah, but I think if just to have a look. I don't think we can comment because we probably want to see a higher power and probably more of it to have a feel of what's going on.
Okay.
Yeah.
Okay.
But anybody else?
Yeah, I
yes.
had the question. Could it be something infectious? Because that's just a question that comes to mind. Could it an infectious process explain what we are seeing with the macrophages and the I have no idea. I don't have any experience with intraocular infections, but just an idea that came to mind.
Unlikely, because you would see a lot more inflammation cells, inflammatory cells. You see granulomas. Those are just foamy macrophages. I think you would say a granulomatous process, because if you think of if they're macrophages, you think of a granulomatous process. So I would expect to see a lot more lymphocytes and granulomas. But it looks on low power, it doesn't look like there's that going on. We can ask Dr. Saumya, do you have any comments? Because in India, there are more infections.
Yeah, so even if, you were exactly right saying that this could be a sort of granulomatous inflammation with, as we are seeing more of foamy histiocytes, but in an acute suppurative endogenous endophthalmitis case, we see a lot of suppuration, necrosis. There will be involvement of inflammatory cells going everywhere, like into the ciliary body, into the angle, into the anterior chamber, into the choroid. So you see a lot of necrosis of the vitreous as well. So primary focus, or it would be the nidus where the organisms grow. So we actually go into those necrotic areas and try to search for the organisms. And even when we do the special stains for GMS or AFB or tissue-grams, we search for the organisms in the necrotic areas of the vitreous.
Okay, thank you very much. Thanks.
Dr. Wairimu, hi, this is Dr. Shruti. I had a question. Was there any retrolental mass? Because I don't see the lens area focused here.
No, I didn't focus on the lens area, unfortunately.
So there was no retrolental dysplasia or a mass there. So what? And there was no calcification also in this case. What do you think was the reason for the white reflex here? Pathologically, are we finding anything?
Nothing that I can explain, unless my colleagues who are more experienced can tell us what they think that was. Most of the time we just report this. I don't even look for
there was no
calcification.
persistent vasculature as well near the persistent hyaloid.
No.
Was that before?
No, I didn't see that. I didn't pay attention to that. Let me say that.
Okay, so PHPV can also be one of a closed DD where we have to look for a retrolental dysplasia and a persistent fetal vasculature there.
But with the foamy macrophages, from what was described in the pathology as a foamy material, then I think this was just assumed to be Coats disease. And Coats disease is one of the causes of a white reflex.
Any chronic detachment actually can give rise to that white reflex. So, and this child also had a chronic, sort of like a retinal detachment as well. That also may give rise clinically to that impression.
That's true. That's true. Although, although clinically,
so simple serious detachment itself can cause a white reflex. Okay.
Another point I wanted to ask Dr. Waweru, did you see telangiectatic cells anywhere in the retina apart from this picture?
I'm sorry, I didn't pay attention to that. But I do take note. I do take note when I see that because of the experience we've had before.
Okay.
But I don't, in this particular one, I don't recall.
So this is a very interesting case. Unfortunately, we can't comment much on the optic nerve, but this always highlights one of the differential diagnosis of retinoblastomas, like Coats or PHPV, or even chronic retinal detachment. So, but I think this case with the optic nerve, were there macrophages in the optic nerve?
Sorry, what did you ask?
Was there macrophages?
I don't recall that.
Yeah,
they were not initially my cases, so I don't recall what I was seeing out here, but I noted that it is not the usual thing that I see. But it looked like there could be a few close to the lamina, but beyond, no. Now I'll make thinner sections. And we see if we see them. What would be the significance if we see the macrophages?
No, it's just that since there are some macrophages, there might be like somebody mentioned, there could be a reactive response. Rather than if you don't see a tumor, then it could be reactive. So it could be a reactive gliosis or reactive some lesions going in. So that would be something that you would consider, because it does look more cellular to me. So if it's not a foreign something else going in, like macrophage inflammation, it could be a reactive gliosis.
It looks more inflammatory rather than gliosis. Gliosis appears more pinker. This is little blue, and if you can trace out through the choroid, you can see a little bit of dipping in that area near the central retinal artery.
So can immunohistochemistry be of help in such a case?
Yeah, so you can do GFAP or inflammatory. If you can see inflammatory stain to see, or for macrophages. But I think at this low power, it's very hard to be sure. But I mean, those are of consideration that you might consider.
Yeah, probably CD68 would help to mark them as macrophages.
Okay.
Yeah. Or lymphocytes, but I don't really see a dark blue. It's just more, all I can say is it looks more cellular. So whether the cellular is what is already pre-existing there, that is like gliosis, or is inflammatory infiltrate or macrophages, I think you need to cut thinner sections and look along and have a look.
Yeah, there's something going on in the optic nerve. Now is to find out what's going on.
So those are, I think, what I can suggest. But I think that's all we can comment. But I think it's an interesting case. I thank you very much for sharing it and making us all think more harder about what could be going on and what other reactive processes you can get. I think it's just about 10:06. Didi, would you like to make any final comments? Or
great cases, great discussions. Nothing to add. I really enjoyed it as a non-pathologist. I hope it was helpful, and I think we agreed to meet once every couple of months with like doing the same. Is that reasonable?
Yeah.
Okay. Any comments? Anyone else? Shabana.
Thank you, everybody. Thank you for your inputs. They have really been helpful.
Thank you,
I think
Kahaki.
somebody raised their hands. Dr. Shabana,
Shabana from Pakistan, from Lahore. Shabana, you're muted.
Yeah, hello, hi. It's really interesting to see the pathology people on board, and a very good learning experience. And yes, I endorse that we should have such meetings frequently during in the coming year. Thank you.
We plan to. Thank you, Shabana. Okay, thank you, everyone. Thank you, Anita, for moderating, and Alexander and Dr. Jakati, and presenters. Thanks very much. And in the next couple of days, I'll send a new date with new presenters and moderators. Thank you, everyone.
Thank you.
Thank you.
Thank you.
Okay.
Bye-bye.
Thank you.
Bye-bye.
Thank you, Kahaki.
Thank you, everyone.
Bye-bye. Bye.